Bismillah ar-Rahman ar-Rahim. Salatu wassalam ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Welcome everyone for our fifth webinar series concerning COVID-19 from the Saudi Society of Emergency Medicine and from the medical education section. I welcome all the speakers, Dr. Alhelail, Dr. Abdo Khoury, and our moderator, Dr. Samah Al-Fahmi. I hope you enjoy this webinar. And without further delay, I hand the mic to Dr. Samah. Dr. Samah.
Yes. Hello and welcome everyone to today's webinar. We're going to talk about the creativity and the emergency crisis resource management during the COVID. My name is Samah Al-Fahmi. I'm a pediatric emergency consultant and I will be the moderator for this webinar. Thank you for taking time out and being here today. It's my great pleasure to introduce this event speakers. I will start with Dr. Mohammed Alhelail. He's an emergency medicine and medical toxicology consultant. He's the chairman of the emergency department at King Abdulaziz Medical City with a great experience during the MERS and now with the COVID. The second speaker is Dr. Abdo Khoury. He's the president-elect of European Society of Emergency Medicine. He's the vice president of the International Arab CriticalCare Medicine Society in France, and I'm sure that he's going to share a lot of good point and experience about the topic. This webinar is recorded, and the record version of the webinar will be available on SASM YouTube channel. Just before we get started, I would like to bring your attention that if you have any question during the presentation, please type them on the question box in your control panel, and I will bring them up at the end of the presentation. Without any further delay, the mic for you, Dr. Alhelail.
عليكم كل عام وانتم بخير والشهر مبارك على الجميع. شكرا ساسم Medical Education, Dr. Rola, Dr. Samah, Dr. Jamil for inviting me to this webinar. I hope everybody get a lot of knowledge and experience from what we are sharing with my colleague Dr. Abdo. I will start first with my presentation, and as I said, we'll keep the question at the end. So we are talking about crisis resource management. So if we talk about crisis resource management, there is a diagram which is already published and talk about many key points, which we'll not talk about at all this point, but we'll try to engage most of this point in our discussion and see how we can utilize some of this point in planning. I will pay more attention on planning and preparing your department to face this COVID pandemic. So if you're working in emergency department similar to this, where everybody is still coming, rushing to your department, and there's crowdness at the entrance, all cases coming at the same time, trauma, MI, stroke, you don't know which one is infected with ARI, the other, some people are wearing PPE, some not. And you're still having people in your corridor and boarded everywhere, and you have your waiting area is similar to this. People are sitting together, no social distance. Then you need to stop and start planning and prepare your department to face this crisis in more strategic and organized way. So every department probably at some level, either they are already ready or somewhat ready, or they just started. I don't think somebody just started. I think everybody now in panic mode and they start preparing. So every hospital and organization need to have a unique planning and strategies. This is the objective. This is what you have to have in every steps when you are planning. So your objective is to provide a safe environment and zero cross-infection in your department, in your hospital. You should make sure that you have a seamless, efficient, evidence-based patient care, zero boarding. This is not the time for boarding in your department. And this is number one enemy in your COVID and all infectious disease is crowdness. You should aim at zero crowdness in your department. apply innovation and lean practice. You must engage all stakeholders. This is not the time you plan your department alone. You should involve everyone in the hospital. Everyone in the hospital has its own objective, its own goal, role, and also be a part of the national plan. And at all levels, you should assure staff well-being. So at this stage, if you have not done this, you should start now. You should have an hospital-wide infectious disease emergency plan. We'll talk more detail about it in the coming few minutes. So the hospital IDE plan should comply with the national and all any accreditation organization, and should have a member from the emergency department, to be the chairman or any lead, and it should be a member from the department in every planning committee in the hospital. And the hospital lead should also be part of the national planning committee. You should not be alone in this. This is a national level, international level. You should not be planning by yourself. So each hospital committee should have multidisciplinary representative. This is the committee that will take the leadership in your hospital, that will plan and execute with every stakeholder, operational and medical, nursing, everyone, and also to communicate with the staff, give them the message, the right message, communicate the national strategy to you, and speak on your behalf to the national level. The plan must be dynamic, should not be one plan that you write it at the beginning, then that's it, you cannot change it. It should be resilient and scalable to respond to different level of surge and outbreaks. So our plan has different levels, 0, 1, 2, 3, and 4. At each level, you should have a trigger when you go to the next level, and what each member of the department and stakeholder and organization do at each stage. It should be written and easily accessible by all staff. It's not like for executive only, it should be by all staff. Everyone has his own rule, and you should practice it. After you finish this, you have to have a detailed plan for emergency department, what to do at each stage, and every area should know what to do at every phase. Also, you should have a backup plan. You make a plan, you think everything is ready, your staff is ready, but they got sick, they're out of the service, or you need more volunteers. So you have a backup plan. A backup plan, what to do when your department, your hospital is full, what you do, when you are gonna deal with it within the hospital or with outside the hospital, or ask for field help. Also make sure that you have enough supply chain, including the equipment. You have, by now you should say, if I am out of this, I'm gonna use this, and this is my source. You don't wait until you are out of it, then you start looking for it. Now the whole world, they don't share anything with each other. Now when you come to prepare your department, you make sure you prevent the cross-infection and the spread if an infection happens. So you have to monitor every chance of infection in your department. You should have a clear case definition that everyone should know. If you ask anyone, like a student, what's the case definition? Everyone should know what is the case definition. You should have an alert system that once you have a case or a possibility infection, that the infection control be aware about it. You should have a system to care for both the suspected and confirmed case during your routine operation and during the escalating outbreak. So if you are seeing 1 or 2 cases in your hospital, that's considered like a routine operation. And later on, when you open your the country open and there is no more restriction movement, then you probably the practice of seeing suspect and confirmed case will be our routine practice. So you have a system for caring during routine and during escalating outbreak. You should be. This is very important. Now most of the hospitals probably they shut down their ER, or they don't see except triage level 1 and 2. But we should continue caring for other patients, because if we ignore them or don't care about, they will be sicker. They might arrive late to the ER, and they will be they will overwhelm your ER. So you have to have an alternative, other channel for this patient to access the healthcare. You must monitor the healthcare personnel exposure. If someone exposed or potential exposure, how to monitor them, how to trace them, how to even if they sit at home, you have to follow them and make sure that they don't present to work except until they're clear. You should have a clear communication system within the hospital and with the external agency. This is number one. If you will concentrate and pay attention to only one information, and this is the key to success with fighting this inside your hospital department, is fight the crowdness. What you will do, everyone is responsible to go and check in every step in the patient flow about area for crowdness. If there is any bottleneck, any area in the waiting, in the clinical, any aspect of crowdness, try to fight it, correct it. This is how you will prevent infection in your department. Crowdness, crowdness, crowdness. You should have an early identification system. This early identification system should alert you when the patient arrives to your department that he is suspected and allocate him in the proper area. If you allow everyone, the patient or sitter or visitor or employee who has suspicion of exposure or have the disease to mix with the other patient, you are allowing to spread the infection within your hospital. Your goal is to have a zero cross-infection inside your hospital. Healthcare, when it gets infected, it crashes. When it crashes, it affects not only your hospital, it affects the whole nation. So some of the scale, if you develop a screening tool like this one, you could develop an area outside your department, like if it is structurally feasible, you can use it. For example, in our hospital, we have a drive-through where we do this screening. Some hospitals adopted a tent outside, or some of them, they have a structure area where everyone can pass through, whoever is the employee or sitter or visitor or whatever, and check them. No one is allowed in your hospital in any gate until he's screened or assessed for potential exposure or suspicion of having disease. You also you need to correct and isolate and fix the structure of your hospital to have a respiratory isolation area. In my hospital, we learned from the MERS experience that we have a permanent solution, that we have a respiratory isolation area. And we have built it, I'll show it to you soon. And this one should be staying with you forever, because we had MERS 5 years ago, now we have COVID, we don't know what will happen later on. So this change should be permanent. Adopt split flow. This is what we adopted in every aspect of our practice. Split ARI versus non-ARI, sitters, patient, sick, not sick. This will help you to identify every patient, and if he's at risk, address his need immediately. Fight the crowdness and start planning the social distance inside your department. Drive-through, there are different examples. One of them is like this, where people in the shaded area will check on the patient, check their eyesight, ask them. They might ask them to leave and not come in if they don't have a reason to visit the hospital or the ER. And sometimes they will identify cases that require isolation and send them immediately to isolation unit. This is the sketch of our drive-through. We have different lane, and we do the ARI screening, and also we do triage away from this area. This is our drive-through that was built 5 years later, 2015, and it's been working continuously, practicing it more than 500 times a day since that time. This is on the right side, the tent. That's the tent that we used during the MERS COVID outbreak. And here you can use it for different reasons, either a triage, assessment, triage away, or isolation and some treatment. And as I said, keep everything permanent. Later on, you can use an advanced ED check-in or disaster screening and decontamination area. And in our ARI isolation unit, we call it the flu unit. Our goal is to see all stable patients that have suspicion to be assessed by a physician there and managed. And the goal is either they go home from that spot or go to a dedicated isolation ward inside the hospital, so they don't mix with the other patient. This is our flu unit. It have 18 negative pressure rooms with its own bathroom, with dedicated X-ray, portable. They don't mix with the other patient. All staff are trained to deal with this case. There is no mixing between staff working this area and the other area. and been functioning well since 2015. And you should also have a flow, how to deal with these cases. And this should be easily accessible by everyone, and this is the price for everyone. Also, this is their patient waiting area, the social distance has been there since 2015, and you should practice this. And you should have a physician to come and assist early and decide this patient need to be isolated or sent to the regular flow. As part of safe environment, you should continuously educate and train your staff. This is how to do a proper safety. So all staff, including patient, should be trained, including how to use their proper PPE. When I say proper PPE, everyone needs to know when to use the surgical mask, when to use the N95 needed, how to use the hand hygiene, when to use it, and if you require a PPR, when to use it, where to find it. Also, everyone has to know how to do the screening. Simulation. Simulation training is one of the important and very useful tool during planning and crisis management and every step. You can pick up area of a gaps area and fix it. So during this training, my hospital we find different gap and we correct it. And also when you are doing a plan how to do, for example, CPR with a COVID suspect code. This is the area when you find gaps and people who doesn't know how to do PPE or they need to learn more. Also, education should extend the patient. To prevent sending the infection to the community, you should teach the patient before leaving how to do cough etiquette, hand hygiene, and how the infection spread, how to do home isolation, and when to come back to emergency department. And if you have a phone that a number that you give to the patient to ask them to call before they arrive to your emergency department, this will save the patient a trip. Also, to give a chance for the patient, if they are sick and they're worried to visit the hospital, not to stay at home. We start seeing some cases that they're not coming to the emergency department because they are scared or worried with infection, and they're afraid of the curfew restriction. Then they arrive too late. So give them a phone number, they call, they feel assured that you are with them, and you can facilitate for them and tell them how to access the healthcare system. You should create a culture of safe environment. So you have to have a monitoring and enforcement system, and you can tell everyone that infection control is everyone's responsibility. Everyone, staff, patient, relative, housekeeper, everyone is responsible for keeping this infection control. Make it as your culture. If you make the culture, make the job easier. Also, you can develop something like an ED visa program. No one is allowed to come in the emergency department if he is sick, he's not trained, oriented how to deal with the infection, or he is he doesn't have any relation with the emergency department. He just come in, passing through, asking the parking. No, only one who has direct patient care, who is trained and oriented to deal with these cases, should be allowed the emergency department. The emergency department has high chance to get cross-infection, and especially if the visitor. This is an example of two messages that were submitted by our organization to the staff. For example, the one in the left is telling that everyone is responsible to take care of themselves and learn and practice infection control practice. The one on the right, every Friday, similar to today, we receive this message to check on the staff, ask them to fill a survey about their health and and if they are having any fever, any symptoms. And based on this, someone will call them if they got any positive symptoms and assure them and tell them what to do. This is to have a way of communication between the staff and the organization. This is some of the training that we provide at the clinical area for every staff. And every beginning of every shift, we have practice for hand hygiene, donning, doffing for every staff, to give them more trust, self-confident that they can do it and they are competent to do it. You should always have an eye and monitor on the equipment and consumable. So assign someone in the hospital to monitor it closely and alert the hospital when someone is about to finish, but not when it finished. Before finishing, what to do, what's the alternative. Also, you should have a system when a result is positive in your lab, what is the flow? For example, in my hospital, when the result is positive, It alerts the infection control. They contact the patient, assess them clinically. Then they send it to the bed management to arrange for them either to go to the quarantine or they need to come to the hospital. If they need to come to the hospital, the message will go to the EMS, who will know the location, wear the proper PPE, and they go to the location of the patient and they bring them in the dedicated ward without passing through the ER. Now you are preventing many exposure to healthcare provider. The problem with exposed patient to the healthcare provider, the more they're exposed, the likelihood that they get infected. Visitor, you have to limit the visitor by now to your department. Limit access, limit the companion in extreme conditions. Strict PPE and hygiene, even for the sitter and companion. Log with the contact information for people who is accessing this area, special isolation area, and provide them with education material. And do video visitation. For example, this is our flu clinic patient sitters. They can visit them through the video. And also patient who is an inpatient, there is a method for video visitation. They don't have to visit inside and transmit the infection from the community into the hospital. If you have issue with the crowdness, you need to think about redesigning the flow of the patient in your department and walk the journey of the patient. If you see any issue that can create cross-infection, crowdness, delay, boarding, you start fixing it and write it down, make it as a policy and make it permanent. Make an overcapacity protocol, avoid any overcapacity or staying or boarding, have a trigger when to decrease the crowdness inside your department. One of the major issues that we learn with experience is how to develop a clearance pathway, clinically and laboratory. So don't allow the patient to stay in your department until they are cleared, because you are accumulating patient there, then you have a bottleneck. Once you develop the pathway, the patient will have a clear flow. For example, our patient, if they will not have the result immediately or not clear immediately, we have a dedicated inpatient ward where the patient will go there as suspect until the result is out. And this ward has well-trained staff since 2015, and they practice it every day. Consider revising the patient flow, so that you have a rapid assessment and management of patient to avoid crowdness. Avoid unnecessary admission to your hospital by developing clinical decision unit and acute admission. Part of our new that we just introduced recently is surveillance unit. Many patients this time, or many people at this time, they need tracing. All this patient doesn't need to come to the emergency department after hour. We have a dedicated area in the simulation center as a clinic where people will go there and swab there. This is an example of the split flow that we apply in our department. They have many units and the entrance, and this is the flow that we design for the emergency department to have people stable and unstable or with infection together. You have to have dynamic, by now you should have a dynamic COVID-19 management protocol that's evidence-based, that's changed as the more literature coming to avoid overuse of resource or underuse of the medication. You have should develop emergency situation protocol or team, modified CPR protocol. For example, the picture you see, we are using a video in the units to avoid crowdness of staff inside the isolation unit and many people staying. You should have an admission and referral protocol and a method of transfer patient inside the organization or outside the organization. And make sure that you're still caring for other patients. So again, I can stress more on splitting the patient, ERI versus non-ERI, sick versus not sick, visitor, patient, and utilize any available space that can use in your hospital. These are some of the innovative ideas that you can use, such as phone triage and telemedicine, virtual clinic. Utilize application for self-assessment. Many people, they are concerned about are they exposed to flu or they have a flu symptom. They can do this assessment to avoid unnecessary visit to the hospital. Satellite clinic to save visit. drive-through, medication refill program, and also if you are the dedicated ARI hospital, then you have a plan to divert to non-ARI hospital. Don't keep your patient without information and they don't access healthcare system. Send regular public message, tell them what to do, let them know what you are changing in your regular flow, and have information center where people can come and call and ask what to do, including medical consultation. Develop a system for decontamination for your department, equipment, ambulance, and consider having many disposable in your department. For example, we noticed in one of our study that if we increase one more cleaning in the department, it will decrease the cross-infection. Finally, I want to stress on the staff well-being. This is a tough time for all of us, a healthcare provider, public. Make sure that you have a good scheduling system for your staff, make them comfortable, avoid cross-infection, movement between area to other area, have a staff pooling and volunteer pooling, train them, develop a system for them for having a health well-being and mental well-being. And for example, in our hospital, we have a hotline for all the staff to call to talk about their stress, their issue, because this is a tough time for all of us. So make staff well-being your top priority. Make all intervention permanent. Anything you do at this stage, make it permanent, because you don't know how long this will last, or if something else will. Fight the crowdness in your emergency department. I will leave it now to Dr. Abdo, and the question I will take it at the end.
Thank you so much, Dr. Alhelail. It's very informative and rich of information. Till Dr. Abdo put his presentation, just I would like to remind the attendees to put the question on the in the question and answer in your control panel, and we will answer it at the end. The floor is yours, Dr. Abdo.
I was trying to get back my microphone. I'm really sorry. Yeah, hello everyone. Masar Khair. I'm really happy to be here with you and be honored by the invitation of the SASM. Once again, they are really kind to me and they invite me again to a conference, one of the conferences. I'm sorry, and thank you for the kind introduction earlier on. I think Dr. Alhelail have spoken about everything and about how to be ready in your how to be prepared and how to do your emergency contingency plans and plan for everything, for pandemics or any kind of disaster. I don't have any conflict of interest for tonight. And going to this pandemic, we all know the dates. Late January, the WHO have declared this as a public health emergency concern, and then the pandemic since March 11. But there are lots of signs that in France, we have end of January, early February in Paris, we have some patients with COVID at that time already. And some of them have left the hospital really well, they recovered from this and with no sequela. And even some people were in ICU, 2 people that were in ICU, and then they also were discharged at that time. But at that time, we were really far behind knowing what's really happening in China. And we were seeing some kind of images from China that makes us more or less worried, but not that much. But now we're starting to see that maybe things were much tougher than we thought and much complex than we thought. There are signs that say that things were happening in China in October with the military games, and then we've got some kind of illnesses in our military sportsmen. They would come back from Wuhan with some kind of pneumonia, atypical pneumonia, but nothing was really documented at that time because we didn't know about that, and we didn't really we didn't really think about something like major was happening. But as long as the days were starting January, early February, alarming signals was coming from Wuhan, and alarming signals were coming from China all over. Despite the fact that there were lots of people infected, very small death rate, although 3,000 people, it's too much, but very small death rate. We're really seeing things alarming, and weren't understanding why China was locked down completely at that time, where the signs weren't that alarming. It was a bit something tricky for us, and we didn't understand exactly. It's a pneumonia, of course. It's something happening, of course. It's a MERS-CoV, new COVID happening, okay. But there's not that much people killed. So why should we lock down? Why should we take all the measures? And we at the French society, the emergency, the European society and the French society and all other societies starting to describe our plans and starting to alert on that and starting to give guidance for what to do in case of having this new SARS or this new MERS-CoV arriving to Europe and arriving to our countries. But you have lots of challenges, and Dr. Alhelail have talked about lots of them, and he's spoken about how to prepare your ED. I won't go once again on that. I agree with everything he said, and I think we should plan before that, plan such kind of events before that. It's not easy to plan everything, but we have to plan the maximum and have a ready plan, a ready emergency contingency plan that we can change, and according to the disaster that we have. Is it natural disaster? Is it chemical disaster? Is it biological disaster? Anything we can do about that. So I won't speak about everything. I'll just take some of the challenges I think that are important for us. There are lots of others, but this maybe I want to focus in my talk on that. About the ED overcrowding, Dr. Alhelail have spoken about that, and I've shown you pictures. We all have our ED overcrowded. It's not something, it's not only in France, not only in the United States, not only Saudi Arabia, everywhere the EDs are overcrowded, unfortunately. And this will lead to hospital overcrowding, and especially when you have a lot of influx of patients with any kind of disease and pandemic or any kind of other disasters, arriving all of them to the hospital, they will overcrowd more your ED, but also will overcrowd your hospital, and your hospital will be in crash. We also faced, and I think most of you have faced, shortage of PPE, and it was like worldwide shortage of PPE. Unfortunately, I was saying before the start of this conference, of this webinar, we in France have had lots of stocks of PPEs and lots of masks, of everything. And unfortunately, some years ago, or even some months ago, we started to destroy all this because they expired, and we never used them, and we never refueled the stocks, and we never thought of some kind of pandemics like this one. We had also some problem with ICU, and I think you heard all over the world, with especially the country most hit in Europe, United States, that you have ICU shortage of beds, but also not only of beds, but also of personnel, because when you work in ICU, you're really highly skilled, and you cannot just like this come and work in ICU. So you need to have some kind of training, some kind of diploma. So building ICUs very quickly like that, not that easy. And of course, when you speak about ICU, we spoke about ventilators, and also we saw this debate about ventilators. So I just more or less focus on these 4 issues, because we don't have time anyway to focus on everything. And I think that these were the major things that we faced, at least in France or in Europe. So just to explain to you a bit my situation, where I come from, is France, and I come from Besançon, the eastern part of France, on the Swiss border. So it's a very nice city, but you are all welcome to visit one day when the pandemic will be over. And this is my hospital, is University Hospital, Referral Center, Trauma Center. We have helicopters, we have ICU beds, we are the referral center for all kinds of disaster for my region, and for pandemics also. So this is Besançon. We are on the border with Switzerland, and this is something very interesting for us, because in Besançon we have lots of microtechnics, and Besançon once in the whole region of Franche-Comté were once the capital of the watches in the world, with Switzerland. Were well known long before Japanese started with the Casio and with the digital watches. It was very well known with watches and with all of microtechnics. And then all this have developed in lots of activities with microtechnics, with all kinds of miniaturizing things and new devices for medical, for spaceships, for space, for everything. So it's something interesting for us, because these industries in time of crisis, because they were all locked down, in times of crisis, they all rescheduled their business, and they were producing for us lots of things that we were in need of. And this is all the area in which Switzerland is very rich with these kind of industries, small industries, small factories, and small startups. In my hospital, as I told you, is a referral hospital. We have the dedicated ICU beds, we have negative pressure rooms, we have lots of things. And it was the plan that to refer all our COVID patients to my hospital in the beginning. But as you know, we have lots of patients, and we couldn't cope with that. And all other hospitals have opened up possibilities. And especially that we were starting to train ourselves, and we are starting to prepare ourselves, because we were really having this alarming signal from China. But what happened very quickly to us, that Bergamo, a city in Italy that is not very far from us, although we have to cross Switzerland, and you see on the, here's my town, here's Switzerland, we have like 600 kilometers between these two cities, between our two cities, and lots of people exchanging, lots of industry exchange, a lot of companies exchange, and have people working in Italy, in Switzerland, in France at the same time. So we're very quickly worried by this Bergamo cluster that has started, and Italy was started to facing a very severe COVID cluster in the region of Lombardia. And we were really impacted nearby. What we have on daily basis, we have our dispatch center. And as you know, emergency medicine, as we believe, is a continuum from pre-hospital medicine up to the ICU. Let's say the pre-hospital medicine, dispatch centers, and emergency rooms. And the emergency physician deal with all these aspects of the practice of emergency medicine. Sometimes we can be in the ambulances, sometimes we can be in the dispatch centers, or sometimes we can be in our emergency rooms. So we deal with all aspects of emergency medicine. And dispatch centers, in the dispatch, we got lots of calls about people worried, about people having some symptoms, or people coming back from Italy with some kind of symptoms. So dispatch centers are very good to predict sometimes pandemics. Not only to deal with the usual business of emergency medicine, but also to predict pandemics and to predict that something is happening, not so good happening, like any kind of the flu pandemic, the flu epidemic every year, the gastroenteritis epidemic, and all that kind of stuff. We can on daily basis predict them more or less. So first we were having a kind of calls. I won't go into details. But at the same time, like some days later, we in the northern part of our region, in Basel, a town in Alsace, on the border with Switzerland also, with Switzerland and with Germany also. There were also another cluster with 2,000 people in one place, gathering in one place. It was a religious gathering, and then more than 1,000 people were hit there, were diagnosed with COVID, and they spread COVID all over France and even to our I would say our other areas in France, outside France, in the Caribbean or in the Reunion or others. So we were really starting to get busy and worry and start to accelerate our preparedness. So we stopped all our activities in the hospital because we knew that it was going to come very quickly to us, and we didn't want to be overcrowded very quickly. So our first challenge was to prevent the overcrowding or crashing our ED and our hospital. This is, in my mind, in my opinion, what should be an ideal emergency medicine department. Unfortunately, it's not in Besançon. It's in Switzerland, in Lausanne, in the University Hospital of Lausanne, in Switzerland. These are cubicles. Some of them are negative pressures. They are all isolated, really simple inside. You see that the strict minimum inside, easy to clean. And they are able to cope with lots of casualties and really isolate them very quickly. So that would be my dream to have something like this in Besançon. Unfortunately, not the case. And even though they built a tent outside the hospital, and this is why we were visiting this, they built a tent outside the hospital, like the one that Dr. Alhelail have shown some minutes ago, and they built them just for triage of COVID. And if they will be overcrowded, they will put all COVID patients here, not to crash the emergency department, not to crash the hospital. They will do what's necessary here, and then they will admit them to specific wards dedicated for COVID. So it's one of the things to do, to just multiply your emergency department and have a pathway for COVID outside your hospital, which is ideal. And if you can have this permanent structures for any kind of disaster, much more ideal. But as you know, in Europe, We don't have that much space that you have in Arab countries, in the Gulf area. And when you are building your hospitals, you're building them with new guidelines and with new, let's say, guidance. And you are building big hospitals, you are building big emergency departments, and you are taking care of such kind of things. Unfortunately, we in Europe are not able to do so. So we are having some kind of not permanent structures that we build when you are in need of coping with any pandemic or any disaster. And also, of course, like China have done, they were able to build a complete hospital dedicated to COVID patients in 10 days. It's something crazy. Of course, we are not able to do in Europe, although there are lots of facilities. Here in England, they built a hospital dedicated to COVID in a convention center. It's a congress center. They've done it, and they really staffed it and equipped it very quickly. Although they had lots of problems with that, they didn't have the required staff to staff this kind of structure. It's not only you have to have the beds, to have the ventilators, but you really need the staff, as I said, and this is something quite challenging to have, even in pandemic, and especially in pandemic. And even if you stop all the activities of the hospital and you start to take personnel from other departments, having ICU personnel is not that easy to have. So this is what we've done in my hospital. We dedicated another area, complete different way. It's not the same pathway. When the patient was arriving to the entrance of the hospital, of the emergency department, there were two triage, a secondary triage, because we've done the first triage on the telephone. But anyway, the second triage was done. And then if the patient is suspected of COVID, we went to the special ER. We were able to open in my hospital, inside the hospital, not needed. We didn't need to build tents outside the hospital. We have enough space in the hospital because as I told you, we stopped all our activities. So at this time, we were able to open up another ward as an new emergency department dedicated for COVID, with simple basic rooms, with simple basic material inside, and lots of and all what we've needed. This is the entrance here, where the ambulance would stop, and then we do the triage again, and then we allocate the patient to any of our cubicles. So when you speak about this, also we usually work with our town medicine, what we call town medicine, or the family physicians and general practitioners, and we prepare this before the crisis. We in France, in Europe majorly, but we in France have a very good developed family medicine practice in the town, and people don't come to emergency department like that. Of course, there are lots of them that are coming, but they are also going to their general practitioner and their family physicians. And we are also working with them as networks. So what kind of networks? With our dispatch centers, here with the crisis have hit, the Ministry of Health have opened a dedicated number for all inquiries about COVID. And if patients were sick, the Ministry of Health at that time, Agnès Buzyn, was telling the people on the radio, on the TV, if you are sick, call the emergency medicine system, which is the 15 in France. And if you are not sick, just call the hotline to have some information. And that's why people have called us in our emergency department dispatch center. Usually dispatch center runs with some kind of personnel, 2 to 3 emergency medicine physicians, 3 to 6 general practitioners according to day and night time, with some dispatch assistant. And usually on daily basis, we ensure teleconsultation. We give them, sometimes we consult them on the telephone. Sometimes we advise them to consult their GP or to go to the ED. Sometimes we send the GP at home, but sometimes also we can send an ambulance or send a mobile intensive care unit staffed with an emergency medicine physician, a nurse, emergency medicine nurse, and the driver to go and, for example, to deal with cardiac arrest, to deal with multiple trauma patients, things like that. So on the daily basis, we are able to do that. But in the time of crisis, because we've got very quickly we were hit from Bergamo and from Mulhouse. I will go very quickly on these slides that I've showed you a bit before. Usually in our department, we have around 600 patients calling us a day, more or less 600 patients. That sometimes we send ambulances, sometimes we give some kind of advices, and see if you see the difference here. Around 500 cases are dealt with by the emergency department physician, the emergency physician, and around 150 to 200 are dealt with the general practitioners. But this is our activity more or less on daily basis. But when the COVID started, we start to see increase in activity, and we got 119 more calls the second day about COVID, some with symptoms, some inquiring about COVID and all that stuff. So we understand that something was happening, and we open up our crisis unit, which is dedicated to dispatch center. It's an extension of the dispatch center dedicated for crisis and for crisis management. That's one example. And we very quickly relied on our emergency medicine residents, the senior emergency medicine residents, some of our doctors to come and reinforce this dispatch center, because very quickly we've got lots of calls having. So it was very simple to do the triage on the telephone. If you have symptoms, the one who was the assistant was sending the call to the resident and to the doctors. If you don't have symptoms, you just call the hotlines of the Ministry of Health, and then people will give them some advices. If you have symptoms, we're triaging them to mild or strong. If they are mild, we're confining them at home at that time. And if they are strong, we were dealing with them with the emergency medicine physician dispatcher, either sending them ambulances or sending them to them doctors to deal with them very quickly. And very quickly, if you see, the calls have started to go very, very quickly and very impressively. We were up to 700, 800, 900 calls dedicated to COVID mainly. And you see the other calls more or less have really went less, because people weren't calling us or trying not to call us, not to disturb us. They knew that we have like a huge activity. So regular emergencies and the people that were regularly calling us were really much less than usual. And then the COVID was more and more, and the general practitioner people, the people they have seeking for advices were calling more and more. So, yeah. And then we extended again our dispatch center, and we reinforced them with med students, with NGOs like Red Cross or Civil Protection, that they came, and then also they were answering the telephones, because it was really something crazy. But we were able to do the triage. What are the advantages of what we've done? So why we are doing the triage on the phone? The advantage was really because, as I told you, lots of calls were coming, and lots of COVID calls were coming on the dispatch center. As I told you, up to 700 a day more on top of our activity, regular activity. And what we were aiming to do with this is to really decrease the load on our ED. And this is what happened. We have lots of calls, but we really admitted few patients. Here, look, 690 patients calling us, only 24 admissions to the ED. So really, we are lowering the admissions to the ED very, unless just when we got our peak plateau, that you have lots of patients, but still 634 patients calling the dispatch center, but only 140 were sent to the emergency department. So it's not too much when you compare. And the same thing happened also in Paris and everywhere else. In Paris also, if you see, they got up to 8,000 calls a day, 8,000 patients calling them a day, and they've sent very low to the emergency department, 300. So by using our dispatch center and doing our triage of the telephone, we were able not to overcrowd our emergency medicine system, not to overcrowd our EDs, and not to overcrowd our hospitals, and ensuring best of care for everyone without being really overwhelmed. At least in my region, some other regions were a bit more overwhelmed because they've got much more serious cases. We've done lots of cases, but we were able to manage this because we prepared. We had a bit of time to prepare. We had much more time to prepare than Bergamo or than Mulhouse, because when we saw Mulhouse and Bergamo, we've really accelerated our preparation. I'll go quickly to other stuff. Challenge number 2, the PPE, and everyone is asking about PPE. Of course, we were lacking PPE like everyone, and the dogma and the guidelines about PPE were changing from day to day. We all know that when you want to protect yourself from any danger, you wear some kind of PPE of FFP2 or N95 or FFP3. And when you want to protect others from you because you are sick, you wear a surgical mask. But the guidelines were changing and evolving because we were in shortage of PPEs, we were in shortage of FFP2, and sometimes we have mild covers, mild while gowns, sometimes we have much bigger. Of course, we have others, the Taisham and the others that we also used, but we really kept them because we're afraid of having lots of patients and not having enough PPEs. So we tried to adapt as much as possible and according to the stocks that we have in our stores. Of course, this kind of protection also, we lacked of them, we didn't have them, and lots of industry have provided us with that. So the mask was provided by lots of industry that were dealing with papers or dealing with tissues or things like that, or with the textiles. They've done lots of PPEs for us, lots of masks also. And these were printed with 3D printers, and lots of industries have opened up 3D printers and tried to do a lot of PPEs for a lot of covered the face shield like this, the face shield like that. We also have different kind of PPEs, and as you know, we were afraid of ventilating people with non-invasive patterns and with CPAPs and with high flow oxygenation because we were afraid to get contaminated because we didn't have PPEs. So one of the sports manufacturers gave us all these snorkeling masks. So we use them for us to protect ourselves, and we've done lots of things with 3D printers to adapt them. We tried to cover ourselves when we intubate, so we are also simulating, and Dr. Alhelail have spoken about simulation, about preparedness and simulation. We trained to intubate under covers, under shields like that also. It wasn't that easy, and I can tell you that. We even gave these kind of masks to the patients because we didn't have enough masks to do CPAP or to do non-invasive ventilation. So we tried to adapt things, and you see the filters, and you see the tubes going to the ventilator. So we tried by any means and lots of things, different things, to adapt ourselves and to be creative. And the industry around us was also helping us a lot in this creativity. The third challenge was the ICU bed and the critical care beds. And I think you've heard lots about the capacity of France, of Europe, of having critical care beds. There are ratios, but there are no rules about the ratio of how much critical beds you need per 100,000 inhabitants. In Germany, they have a lot. We are more or less okay. In Italy, they have less on that. And you see that all the cuts and all the hospitals and all the governments have these recent years, these latest 10, 20 years, have done lots of cuts in the budget of the hospital, in the budget of the healthcare. And one of these cuts was in reducing the hospital beds, in reducing the ICU beds. And I'm not telling you something new. You all know about this. You all know these figures. So we were in shortage of critical care bed, and different regions in France and in Italy also have done the same. They tried to transfer people when they were really, really lacking of beds. First, we tried to push the walls. We tried to increase our capacities. In my hospital, we have 40 beds, ICU beds. When I say 40 ICU beds, because in France, we have two different ICUs. We have the ICU, the real one, the heavy one, with big respirators, with big ventilators, with ECMOs, all that stuff. And you have also what we call the small ICUs, where you can just monitor a patient for just single organ failure, either to ventilate with non-invasive pattern, to do dialysis or things like that. So our heavy ICU was, in my hospital at least, we pushed the walls and we just created new ICU beds, and we pushed it from 40 to 90 beds. But once again, it's very complicated to gather all the staff and to put all the staff on everyday basis to watch out for 90 beds when you are usually you have the capacity for 40 beds. So when you arrived around a critical level of ICU capacity, we started to do lots of transfer toward the regions that were less hit from the COVID. And you see with different means, with the militaries here in my hospital, with the militaries, with private jets that are used to do usually medical business, with trains. We just had trains, and we trained about them last year. Last year we had the big exercise in Paris, and there was part of it there. And we went with the train from Paris to the eastern part of France, where they were most hit this year. And we trained about to take lots of casualties We just simulated a mass attack at that time and multiple casualties, and we just moved them to Paris. So we simulated this, and we simulated the capacity to go in the train. And this year, with the pandemic, we've done 10 trains or maybe 12 trains to transfer people. We use the cargo of the army, and this is a huge, and you see it inside. It's a huge ICU, mobile ICU. It's the biggest in the world. It's the only one that exists in the world like that. It's a military one capacity of bringing ICU people and to operate them on board while flying. So it's something very expensive and very heavy to put in place. Helicopters and other stuff. So we've done lots of massive. I thought I had another figure. I'm sorry. We have lots of massive things to go toward south of France. These were the regions that are less hit in the crisis. So we've taken people from ICUs from the regions that were the most hit to the regions that were less hit. And finally, about ventilators, we all know about that, and we all spoke about that. And lots of people started to create ventilators, basic ventilators, sophisticated ventilators. All the school, engineering schools, Harvard, MIT, in my university here, in Brest, all the stuff. And you got lots of ventilators plans on and schemes on the internet, running on the internet. And this one of the models, look, see how basic it is, but it's a very nice one. But I'm not sure it can be possible to ventilate a real COVID patient with it. It's a SARS patient, ARDS more or less having. So it's complicated to ventilate with such kind of ventilator a patient. But anyway, when you run out of ventilators, you need some kind of things to do. And this is one of the ideas that were described and were published and were presented to the media and to everyone. But also, and I think that you probably heard about this splitting the ventilators to provide ventilation to people. Okay, as not as definitive support, but as waiting to another option in the emergency department, for example, waiting for a place in ICU or waiting for a transfer to another hospital or something like this. And United States, FDA, and all others have really considered this seriously to split ventilators. We even also try to do, we modelized this. We have already published about splitting ventilators in animals some years ago on simulators also. And this simulation we've done with the team from Brest, from the west of France, and we adapted for monitoring, because when you put a patient, 2 patients on one ventilator or 3 patients on one ventilator, you cannot monitor every patient with what every patient is taking. But when you adapt this kind of device, this device that it's called EOLife, that we in my university here have developed for cardiac arrest. This is kind of monitoring for cardiac arrest that will help the healthcare workers, the emergency physicians, the fire department to better ventilate a cardiac arrest. And so this device, with the company that is producing it, actually Archeon, we developed it very quickly, and we developed another interface to be able to monitor the ventilation of the patient. So you see, in times of crisis, this tool was dedicated to cardiac arrest. We were able to switch to create something more and to adapt something more and to adapt the software to be able to monitor ventilated patients. So if you put it on multiple patients in one ventilator, it can it can be used for that also, and it can be much more accurate than just putting the patient on the ventilator. So what's positive in all this? Positive, of course, we saw it was creativity of everyone, of the staff in the hospital, or of the interface we had with the engineering and with all the citizens around us that all were calling us saying, how can we help you? What can we do for you? And this interaction that the doctors and the healthcare professionals never have with industrials or never have with engineers. And this is the first time that such kind of combination of teams were done. And another positive thing, that emergency medicine was really the center of this major healthcare response. And we, with our medical dispatch, with everything we've done, we're able to flatten the curve. Why it was important to flatten the curve? It was important to flatten the curve, not to go up over our capacity, our hospital capacities. And this is why, with all these measures, we tried hard and we worked hard to try to flatten the curve. But once again, emergency medicine have done great in this period. And for the first time ever, I think, emergency medicine were really under the spot of the media, on the spot of everyone. You see on all the media, every time we have expert in medicine, there were always emergency medicine doctors as expert on the TVs and everywhere. Right. And I think I'll close here, and I'll have to pay respect and tribute to my team, of course, but to all the healthcare professionals that really work hard, and to all our friends and colleagues that also have died with this, unfortunately. Thank you again for the invitation.
Thank you so much, Dr. Alhelail and Dr. Abdo. Dr. Abdo, it's really very interesting to have a different perspective of management and operation while dealing with this crisis. We have a few minutes to take 2 questions, and I will go for the first question for Dr. Alhelail. Thank you, Dr. Alhelail, and this is from Dr. Abdulsalam. Very nice presentation. MERS, COVID emphasized the need of the disaster management plans, and it's clear from your presentation that you have learned from the previous experience. The question is, what about the other hospital? Did you involve them in the preparation and in the plan, including the external evaluation and the clear pathway and backup? So he's asking about the involvement of the other sectors.
Yes, I think we have advantage in Saudi Arabia. I will not say my hospital, the one who got advantage of the MERS experience, but I think the whole country has learned hardly from that experience, from the MERS. And during this time, the MOH was implementing many policies about infection control and tracing case of MERS. Maybe in the last few months before the COVID, people start getting more relaxed. But I think the whole country has developed some experience. It was not an easy one. I agree with you, having practice how to respond to similar scenarios, especially now, if you think about the hazard and vulnerability assessment now. We think Saudi Arabia has exposed before, now the world is exposed. So any future plan should include the scenario of such pandemic. That's why I'm saying anything you do during this crisis in terms of response, preparedness, response, or soon, inshallah, we will start doing the de-escalation plan. So the escalation plan should be start now, actually, not be at the end of the crisis. You should start now how to go back to normal, how to survive and live with this COVID, because it's not gonna end as like this day, everything will disappear. So anything that you have prepared or purchased or you did, make it a permanent, write it down, make it a pathway. You're gonna use it for a while, inshallah, very short term, but if it's say longer, you want it to be staying with you. And what if the virus changes its name from MERS to COVID to anything else, you still can use it.
If I can add something to Dr. Alhelail, we at our hospital, as we stopped our activities, we stopped all the activities. So we stopped all the planned activities, we stopped all the elective surgeries. We just only ensured the emergencies. So all our surgeons, all our doctors, other doctors came and helped us in the sector, in COVID sectors. For example, our trauma surgeons were enrolled in the ICU to just come and put the patient on prone position. So they were like a brigade for coming to the ICU and helping the ICU staff to put people on prone position. All other doctors came to all the COVID sectors and helped us in seeing the patient of COVID. They came to the dispatch center helping us. So all the hospitals were more or less directed toward COVID response, and everyone have really played a major role in that. And another level we've done also coordinating with other hospitals, not only with my hospital, but with other hospitals also, to be able to dispatch all the people in ICUs and in the emergency department, not to be overcrowded at any single time. And this also helped us with this kind of organization.
Very interesting. The second question for Dr. Abdo, we saw the variations in the number of the COVID and non-COVID cases that visited your ER. During the planning, how do you maintain the balance between the care of COVID and non-COVID without harming the non-COVID patients?
As I told you, on different level. The first level of the dispatch center. The dispatch center, we have a room for dispatch. It was kept like that to deal with the regular emergencies. And as you saw in the figures, we, instead of having 600, 700 regular emergencies every day, it dropped to around 400, while we got 800 more just really specifically COVID. So the major dispatch center was kept like that, with the same organization, with the same number of people answering the calls and dispatching ambulances and mobile intensive care units and everything to ensure regular emergencies. And the extension of this center with our residents, with our general practitioners, with our NGOs, all that stuff, were really made for responding to COVID. In our emergency department, it was the same case. We, of course, downsized our emergency department and downsized our response in the emergency department because we observed that we got less people coming to the regular emergency department. And so we increased the load in our regular emergency department, but we put more and more people in the COVID sector and in the COVID areas. And that's why we were always ensuring the best quality of care for everyone. And we didn't really have to choose between one or another patient. The problem that happened, that patients were afraid to call us and were afraid to come to the hospital because in their imagination, first, they were not afraid. They didn't want to put more burden on us, but because they knew and they saw it on the TV and on everything, they were dealing with lots of patients and we are dealing with really overcrowded, although we were never overcrowded. And at the same time, so they didn't want to bother us. And at the same time also, some of them were afraid to come to the hospital and to catch the COVID. They say, I'm at home, I'm good. Also, I have chest pain, but I want to catch the COVID. So some of them at first didn't go. But now with the more or less decrease of the COVID patient, we are seeing an increase back of our regular patients.
Okay, thank you. So I will raise the last question, and I need the inputs from both of you regarding the tent. How did you manage the AD flow, and where is the visual triage exactly based?
So there is two actions. First, when we had the tent in the mayor's OV, it was outside the department at the entrance, the main entrance. That time we had different experience. The emergency department the hospital was shut down, and because the outbreak in the hospital, so we had to have a diversion, and that unit were the main access to the emergency department. But now, after we did the transformation and restructuring of the flow and design, the drive-through is outside, do initial assessment, mainly ARI, and send direct patient to the acute respiratory unit. And in every unit, there is a secondary scheme because people, they will park, they will walk in. There are some people who doesn't want to go to the isolation unit. They will walk into the main ED. There is a secondary assessment in the main entrance where they will do a second assessment. Outside, the patient still can go to main ER or go to the isolation. This can be done outside in a tent in other hospitals, or if you have a room outside that can be converted to visual triage. The most important rule, do not mix people with ARI and ARI inside is about waiting for assessment. This is the area where we had the previous exposure and outbreak in our department.
Good. Dr. Abdo, any other thought? Yeah.
As I told you, we had the triage outside the emergency department. So it was the triage nurse were outside the emergency department, and if any patient was walking in, she will, with her triage, either convey him for the COVID sector or for regular sector. But as you saw in my slides, the Ministry of Health and all the media have strengthened the fact to tell people not to come to the emergency department, but just call the number of the dispatch centers. And the dispatch centers were already doing the first triage. And with the first triage, we were straight sending people either to COVID or to non-COVID. with ambulance or without ambulance. So we got lots of pathway like that. For example, when we had a stroke or something like that, we're sending them get straight to the neurological ward or the neuro ICU very quickly, and not making them pass by a regular ED or by the COVID ED. So we were doing the first triage on the phone with the dispatch centers, and if someone was coming alone to the emergency department, there were a triage nurse outside the emergency department that were dealing with this and putting people in either ways.
Great. Thank you, Dr. Alhelail and Dr. Abdo. It was really great, and I apologize for those we couldn't raise their question and answer it, but thank you, everyone.
Answer their questions somewhere, or even like private.
Okay, I will figure out and raise it to you if through the Twitter account maybe, so we can post it there.
Twitter,
okay.
Yeah, sure.
Perfect.
Or any kind of social media, no problem.
Perfect. So thank you, everyone, and thanks again for joining us today, and we will see you, inshallah, next time.
Thank you.
And on behalf of the Saudi Society of Emergency Medicine, we want to thank you. It was a pleasure. It was amazing. We had more than around 220 participants, and this will be recorded as well, and will be shared again in the social media. And looking forward to meet you guys in person after this is over, inshallah.
Thank you, Dr. Jamil. Thank you.
Bye.
Thank you, Dr. Alhelail. Thank you, Dr. Abdo. Thank you, Dr. Samah. It was really informative and very nice presentation and webinar. Thank you very much for the attendees as well. Good night.
Good night.